Okay, today's webinar titled State Medicaid Leadership Perspectives, Managed Care Pathways to Healthy Equity Through Food as Medicine is brought to you by Mom's Meals. Mom's Meals is an MHPA Silver Partner and longtime supporter of the association and our health plan member. Actually, I think they were partners well before COVID stuck with us, so we really appreciate them. I want to thank the entire team at Mom's Meals for convening today's distinguished panel. And with that, we'll turn things over to Tim Conroy, Mom's Meals National Vice President of Government and Healthcare Partnerships. Tim?
Thank you for that introduction, and thank you, MHPA, for this opportunity to share some state perspectives on food as medicine and some of the rising opportunities to support at-risk populations. My name again is Tim Conroy, Vice President of Government Healthcare. I'm privileged to introduce today two amazing people. First off, Kathleen Doherty. She is the Chief of Managed Care Operations for the state of Delaware, and also Stacy Weeks. She is the Administrator for the Nevada Department of Health and Human Services. Really pleased to share their perspectives from their states and some national innovation around what's going on around food as medicine and how we can all partner across our health plans and state governments to make sure we're targeting at-risk populations. Just real quick, we're going to get into some discussion and just open this up for Q&A at the end here, but we wanted to start off just setting some very basic baselines on food as medicine. It's a big buzzword right now nationally. A lot of people are discussing how do we as a society support some of the simple pathways to food security. But we wanted to just highlight some things that are happening now. We want to give a landscape of what's occurring and maybe highlight some of the current pathways that are occurring right now, what we can all partner together to drive outcomes for, again, high-risk populations. You know, as we all know, one of the main lifestyle risks for chronic conditions is poor nutrition. As individuals age, they get more chronic conditions and become polychronic. But for any population, when health plans or state governments are targeting communities that have been left behind with some health inequity challenges, right, food security is one of the simple, practical ways that we can all work together to really target improving outcomes, promoting dignity, and reducing some of the unnecessary costs that are hitting the Medicaid system and the healthcare system in general. Right, but when we're talking about more generality, the mortality rate for people with food insecurity is 46% higher than those that are food insecure. You know, food insecure families spend about 20% more on healthcare costs. And just in general, good nutrition drives about a 20% lower cost of care for individuals in the healthcare system today. You know, so although we know we can control cost, some of the outcomes measures, we're starting to see more and more visibility around waiver HEDIS measures, but just in general, things like food security and programs around food as medicine can help achieve very good clinical outcomes, reducing blood sugar levels, controlling blood pressure, you know, helping reduce weight, really driving outcomes around our highest risk populations with chronic conditions to make sure they're able to age in place in their chosen home environments. But just in general, 1 in 6 seniors face hunger. So as we talk about different pathways to food as medicine, the senior and aging population is a big opportunity for us to partner together with. In general, 45%, there's an increase in food insecurity over the past 2 decades. And this is pre-COVID, right? So now that we're talking post-COVID, those numbers have only increased. And we're only seeing exacerbated rates of food insecurity specifically around populations that have been left behind in some of our access issues. And last but not least, there's a 4 to 6 day length of stay increase of the hospital for people that are malnourished. So both going into the hospital and coming out of the hospital, how can we target, support, intervene, and bring access to healthy food to people at risk for disease exacerbation? And we're going to talk in general about some of the Medicaid work happening. You know, the kind of the payer of first resort is typically Medicare, but we see opportunity where state governments are starting to innovate, where health plans are really working with state governments to innovate around the Medicaid pathway. On the left here, home and community-based service waivers, they've been the foundational work of food as medicine programs. A lot of states have home delivered meal programs and medically tailored meal opportunities on their home and community-based service waivers. Those are evolving and modernizing. We're going to talk about some opportunities with those today. A, to drive better utilization, B, to really make sure we're targeting person-centered outcomes for people on waivers. But as we all know, that's anywhere from 4 to 6% of the Medicaid population. So although that may be the safety net, it's not available for those not on waiver programs, which again is a very small percent of Medicaid. Next, Medicaid target populations, that's where we're seeing the biggest opportunity for innovation. So one of the reasons I wanted to highlight 2 of our presenters today, both Stacy and Kathleen, they both worked in their state to really look, okay, how do we modernize, how do we partner with health plans, and how do we all raise the bar and how we target food as medicine for these individuals across their states? 2 of those pathways, the first in lieu of services, we've seen a lot of guidance. January CMS released guidance. Subsequent to that, there's additional guidance on how to make in lieu of services a pathway to cover food and nutrition programs for high-risk individuals. Many states are starting to look at those pathways, both as a potential permanent pathway, but some are using those as foundations to start bigger and kind of more broader 11-15 demonstrations. All right, and these are the programs where it's a 5-year cycle. They get renewed every 5 years, but they're considered by CMS to be some of the kind of the traditional baselines of where food as medicine can be covered. Now, there's existing 11-15 demonstrations that may not have food benefit pathways on them, and there's new demonstrations that are built around food as medicine initiatives. So, from A to Z, our goal is to really talk through and really identify ways that, again, state governments, health plans, provider groups can all partner together to make sure food as medicine is becoming a viable pathway to support food insecurity and health and equity for high-risk populations. All right. So I wanted to reintroduce Stacy and Kathleen both. Thanks for joining us today. And I wanted to open up the conversation and just let you all kind of comment first and foremost as state Medicaid leaders. How do you see, partnering with health plans, and how do you see that partnership with health plans within your state Medicaid program helping target, social benefits and things like food as medicine?
Stace, you want to go first?
You can go. Okay.
Okay. So, again, thank you for convening this and very important topic. In the state of Delaware, we have all of our benefits through 1115 waiver, and we have managed long-term supports and services. So we've had that since 2011. So we've had a lot of years to kind of get it up and rolling. We have our skilled nursing facility, our HCBS, our IDD population, and behavioral health all in one waiver. So we kind of have everybody in one place. One of the reasons that, the state of Delaware initially went to managed care, and especially MLTSS, is because at a fee-for-service level, we couldn't do what we needed to do. We didn't have the staff. We just weren't prepared for that. So we go out, we get a managed care organization to help us with this and partner. But that doesn't mean that all the issues and problems that we were having as a fee-for-service state just magically disappear when you get a managed care. So you can't expect our managed care organizations that, bid on our work in our state to be able to just, wave a wand and all of these issues go away. So I think really partnering and really having an open line of communication to look at individual level issues to partner. There are some things that the managed cares want to do that can't do because it might be not in a state plan. It might not be in a regulation. So that partnership to be able to move your program and mature your program to where you need it to be have to be constant. Yeah,
good point. Stacey, what are your thoughts? Delaware is obviously a MLTSS state. What are your thoughts in Nevada and some of the ways that your waivers have been structured historically?
Yeah, so ours is a little different. I wish we did have everything under one waiver. That sounds really nice. I know that's probably a bear of a waiver, but so I do not envy that. But it is challenging because we have different delivery. We have a fee-for-service program for our seniors, our Medicaid, age, blind, disabled, MABD population, still fee-for-service. I do think there are gaps there in helping that population because of that. So I agree on that piece. Right now, our managed care plans really are what I would consider sort of our mainstream plan for families and children, adults without children. And it's not statewide yet. So it's only in and Nevada is a unique state. So most of 90% of our population is in 2 counties. So you think of Vegas, Clark County, and then you think of Reno, Washoe County. Mm-hmm. We are going statewide soon. And I think one of the things I want to, try to be very clear with my plans what are the expectations we have for them? And really it is about helping the communities that they serve. We have a community reinvestment program that we use, and this is a big thing that we try to push some of that social determinants of health piece in. Some states already have this. They have, in Minnesota where I used to work, we had at one point only nonprofit health plans, and they had to do community reinvestment, right? So now it's really just kind of taking that model and doing that here. So 3% of their profits go back to a lot of things around housing supports. Some, it can be food, it can be anything around social determinants of health. Mm-hmm. And then also we have that in LUA program we're putting in place. But it's really focused on the population that, lacks housing, that's at risk of homelessness. So a lot of times it's going to be individuals who have serious emotional disorder, SMI, serious mental illness, substance use, all the things that I think that go together with being at risk of homelessness. So that's what we're focusing on right now.
Great.
I'll stop there. Yeah.
No, good point. And turn it back over to Kathleen, and for both of you though, right? And the pandemic was impactful in so many ways, right? One of the things coming out of the public health emergency as well was some flexibilities with some of the current waivers. Right, I know those flexibilities are going away, but maybe start with Kathleen. I know Delaware did a lot to guide the managed care plans on ways to maybe during the flexibilities, right, use some of the PHE flexibility to maybe target, their waivers, looking at the programs, maybe help the audience appreciate, what happened in Delaware during the public health emergency and how that, allowed your waivers to have a little bit more flexibility in targeting food insecure populations.
Well, there isn't a state out there that didn't jump on every K waiver coming down the pike, right? And if you've been in Medicaid, for a long time and working in the state, anytime they're giving that wide open, it's like a dream, right? Everything you always wanted, and somebody said, "Here you go." So, it was a good way to kind of test out things that to help individuals and help our membership to be able to really survive during that pandemic. And many other states did the same thing. One of the things that we did is when we first brought our 1115 waiver up, we put in 1 meal a day for our MLTSS program. We kind of wanted to. The discussions with CMS were not kind of going that way. So, and again, long time ago, right? The discussions were probably 2010. We decided during the waiver and to put in 2 meals per day for all of our MLTSS. Soon into that, even in the first year, the uptake on that was tremendous. We found that what we really thought there was a need. Now, it wasn't all just individuals who their day programs closed and, they needed an extra meal because they weren't getting it at their program. It was individuals who were not in a day program. So we really looked at the data, looked at the utilization, who's using it, who needs it. And we decided a year in that we were going to amend our waiver. So we weren't going to wait till the end of the authority to then ask. We figured we would be among, every state asking, and knowing it would be backed up at that time, which of course, if you know anything about that, it is. And we will be waiting a long time for approval from CMS. Not that they're not working as hard as we are, just that they have all of us sending them everything. So we amended our 1115 waiver a year ago to allow for 2 meals for everyone and 3 if needed. If a care coordinator is looking at, a targeted, independent review and we're looking and they offer 3 instead of 2, that's good, right? There was a need for it. They found it during an assessment. So it's really served us well, and our utilization rates are really high for that program. We're above 50%, I think, running about 50% to 60% right now. And not only are they getting it, are they eating it? So there's a lot of questions you have to ask. Just because it's getting delivered doesn't mean that they're consuming it. So really having those broad discussions, that patient-centered. Is this what you want? And so it's worked well.
No, good point. Stacey, I don't have any thoughts too. And I know programs are evolving, and again, the PHE flexibilities just recently, and it's some extensions were granted too, but what's your perspective in Nevada? And, again, looking at the temporary exacerbation of food insecurity, even though it was already a challenge across the country, right? The pandemic caused a lot more exacerbation of those issues. Like, what do you see Nevada's approach to maybe utilizing some of the PHE flexibilities, but moving forward with some of the waiver language and food insecurity projects?
Well, we don't do the waiver. We have a state plan benefit. So it's a little different for us. I think what you see coming out of it is this new recognition of. We've all talked about social determinants of health for a long time, but they're even calling it healthcare. What is it? Special need or something special? There's a new social needs, special needs terminology for it. There's always a new acronym every day. Yeah. But I think there's a new recognition coming out of the PHE. I think beyond the flexibilities, which were great, I think what I really value from that experience in Medicaid was the partnerships that were strengthened with our providers, with our plans. And instead of us feeling like we're different sides of the conversation, we're actually they were more on the same side about what our goal was, right? It was less about the financial pieces, it was more about how can we help. And I think those relationships and leveraging each other, I think those are the things that we're trying to still continue. Because that to me was the biggest value coming out
Right.
of PHE was the new partnerships that you saw coming through all
Absolutely.
states, I think. Yeah.
And it seemed to open up a lot of communication between your plans in the states, right? Because you almost had to respond to like imminent need versus, maybe some historical things where it's not as like imminent, right? With those conversations. So I love seeing that communication constantly evolve and improve.
And
Kathleen,
humanity, right?
yeah,
Like I think
absolutely.
Right.
it brought back humanity. I'm not saying our world doesn't have humanity in it, but it really brought to the forefront, right? Our decisions were less about fighting over we did fight over some dollars, but it's a little different. It was about helping. And even with the PHE unwind, I think we're still partnering in that way. And yeah, there is a business need there, but I think at the same time, we all value the need for people to have coverage, and especially in the middle of a pandemic, it was a big deal. So
Absolutely. And we talk about some of that, right? And again, you try to look through a perspective of, okay, what lessons learned, right? And to your point, the humanity of, right? And Kathleen touched on some of the flexibilities with the waiver during the pandemic that were continued. But end of the day, you all, right? That's what, we noticed from a national perspective looking out, right? As the health plans partnered with the states to really identify coverage, right? And then social benefit programs, because end of the day, right? If someone's not consuming food, right, they're not going to have healthy outcomes. If they have socioeconomic challenges, or they have chronic conditions, if they have access issues, right? How do we have the basic humanity of getting healthy food to people? And Kathleen, you touched on like person-centered care planning, right? Like again, and how do we make that a practical way to get person-centered needs to individuals so they consume the food? Like if it's not meeting their cultural needs, if it's not meeting their specific needs and choice needs at the local level, right? If they're not consuming the benefit, we're not going to get the outcome from the benefit. So really driving that from a person-centered approach. Kathleen, you touched on one thing real quick. I'd love to, maybe if you could help the audience understand. You mentioned like some of the utilization with your current waivers up to 56% of the population. I think that's something great to highlight. Especially under the 1915 home and community-based service waivers traditionally, right? Some states ask me every day, like, our utilization is like 5 to 10% of our population on meal programs. What are we doing wrong, or what can we do differently? Or what can we learn from the pandemic? So I don't know if either you have any thoughts, because that's, we haven't seen CMS restricting, right, meal programs on these waivers as long as they're validated. So I don't know if you have any thoughts for, other states or health plans on the call that really want to target how to get better utilization with existing waivers.
I think it's all about how you ask the question.
Yeah.
It's how you go about the approach. If you ask an individual, do you need help, with food?
Yeah.
9 times out of 10, the answer is going to be no.
Right.
There's a pride streak that runs through, most everyone you ask that question to.
Absolutely.
No parent is going to want to admit to someone that they don't know, they just met, that no, they're struggling feeding their children. It's just not ingrained in people around that, because at our basic, you feed yourself and you feed your children. So I think that asking the question and how you ask it, not just ticking it off as a checkbox, really makes a difference. And I think that if your utilization is low, you have to look at who's asking the question, when the question's being asked, and how you're asking it. It shouldn't even be necessarily a direct question. It should be part of a conversation. It should be, listen, did you know that we have this program, and a lot of people are taking us up on it, and it can really help with this? And don't come right out and ask them, do you need help feeding your family? It's rarely going to happen. So it's more about a conversation, about trust, and then timing the question itself and the timing of when you ask it in an assessment. And I think that if plans look at that and really test it, when our utilization was low, we did mock interviews with our MCOs to really get to the idea of where is it going wrong. And it was, and if they're overworked, right, they have less time with more people, and just like all the rest of us, but changing that dialogue really made a difference in Delaware.
Great point. You touched on too, and to your point, it's right. And as we work with health plans too nationally, right, they want to know how to support the state in meeting those goals, right? To your point, who, what, when, like asking the questions so that you're allowing that person to maintain that dignity, right? We know a lot of these waiver populations are just technically food insecure. That if you are low income and you have a chronic conditions, your access to healthy food that meets your needs to to sustain health and well-being is limited, right? So, and to your point, like, how do we make sure those questions are being screened with dignity? And at the same time, right, I know a lot of states are working with CMS right now to make sure the waiver language represents that too. So there's not disqualifying factors like other services that are provided. You mentioned personal care and adult daycare programs, that food insecurity has a multi-tiered approach to it, right? And these waiver programs should address those needs on an individual basis. So, I appreciate those comments. Stacey, any thoughts on your side from Delaware? And again, I know it's a different system, but you mentioned the dignity aspect and humanity aspect of it.
Yeah, I mean, I think we're still in the early stages of implementation, so it's hard to, I think, know what advice to give.
Mhm.
I do think the dignity thing is a big deal in Nevada.
Yeah.
I think a lot of individuals are eligible for Medicaid and they won't even enroll. So I think
Yeah.
our challenge is the front door.
Yeah.
There's a lot of pride. And so how do
Mhm.
you help people and not stigmatize them by making them come through a special door to get it? Like, I think that was the whole goal of Affordable Care Act. I don't
Yeah.
necessarily know if we're still meeting or getting there all the way yet nationally. But I think the struggle will be people accepting it and not feeling, losing pride and all those things. But I think that our health plans, especially in the rural areas, that's going to be
Mhm.
new for them. They're going to be
Yeah.
going statewide in 2026. So my hope, and I've been saying this to them, is please get out there and meet the community. Please get to know the hospitals, do
Yeah.
your, we did a rural tour ourselves, and
Mhm.
it's really important to understand the communities. They're all different. They're not just all rural, right? Like, each community is unique and different. And so I think building trust is the hard part too for our
Yeah.
plans. Mhm.
Especially with the social benefit, that trust factor, to your point, is critical, right? And I want to celebrate our health plan partners on this call too. They're listening and adding in questions. Patrick just said, or keep your questions coming in Q&A. We'll turn that over here in about 10-15 minutes to audience participation. But and to your point, right? How to part of our goal is to really just make sure, right, we're connecting the dots and making this simple, practical, person-centered, right? Because end of the day, food is medicine, and our goal is to make that process as dignified and person-centered as possible. So switching over to some of the more, I guess, innovative ways now, right? The home and community-based service waivers have always been kind of that safety net baseline in the Medicaid program, right? And to Kathleen, your point, right? We're looking at ways to make sure those waivers are utilized most effectively, efficiently, right? From our health plan partners and our AAA groups and different groups in fee-for-service states. But as we move into more food as medicine and kind of that non-waiver, traditional Medicaid population, what are some pathways you're seeing? You each have really taken a leadership role, I think, in two different pathways. I know, Kathleen, you're doing a lot of 1115 work, and Stacey, I know you're working in lieu of services. Kathleen, if you don't mind starting, just where do you see the pathway for that additional innovation with 1115s and other programs for the non-waiver population, the more traditional Medicaid population?
So one of the things that we're doing right now in Delaware is
Mhm.
during the pandemic, and Stacey brought it up, that we found that partners working with each other and
Mhm.
really getting down. It was not necessarily looking at negotiations and everything out. It was like, how do we all help?
Yeah.
Our non-emergency medical transportation provider, Motive Care, came to us and said that we're, nobody's going to a doctor's appointment, right? And we're afraid that we're going to lose our drivers. Is there can we help you in any other way? We want to keep them employed because getting them back is going to be extremely difficult, and they need to do something because they need to get paid. So looking at the big picture thinking. And so we developed a pilot program in the state of Delaware for individuals who were postpartum. So we were delivering food boxes. Well, we didn't have anybody to deliver them. So we said, how about if your drivers deliver our food boxes, to our postpartum, for 8 weeks postpartum women. So we did that, and we in the boxes, then we started adding diapers, and then we added wipes, and so then it was a food box, and it was diapers and wipes, and everything was good. And logistic care was just, or whatever they're called now, Medicare, just coming in and picking up the boxes and deliver them to the individuals. But we couldn't have done any of that without a partnership with our MCO plans. So I'm like, there's we run a whole program, and there's 5 of us that do it all. So how can you help us? And they said, we can help you. We'll get the people we know who are just coming out, of giving birth. We can get family size to see, what meals were needed, how much food for the food box is needed. We'll help you coordinate. So it was like Stacey said, everybody just came together, and we ran this awesome pilot program that had some great outcomes. Well, after running that program, We, of course, we need funding, got some funding for that because, there was money coming. We waited our entire lives for people to throw money at us. I was grabbing it left and right. So, we did this program and we had such a great result that we decided to, instead of waiting to see if we had funding again for it, we decided to put it into our 1115 waiver. It really worked. And it's been a lot of discussion with CMS. And as you all know, that they are pretty far behind right now in approving waivers. But and we said that the good part about this pilot was that adding that diapers and wipes and the success that we have for individual women who are meeting their HEDIS goals of, their 3-month postpartum visit, the first baby visit, where, one of them, I think, was at like 92% of the women in the pilot went to their postpartum visit because they stayed engaged with their case manager. We were bringing them food. They weren't so stressed. There was diapers and wipes. So the discussion with CMS right now is we wanted to keep it as a package. We didn't want to parse it here, have some in lieu of, have some in, the SDOH, and we wanted everything else we have is here. Why would we start now piecing it back out? We finally got everything in one place, right? And so they agreed. They're allowing us to keep it in there. There's some few more metrics about how we're going to capture that and what, kind of medical necessity or health related risks are needed for an individual to, I just wanted to say, well, if you gave a baby, you should be able to be on the program, or, we're still under discussion. So, that's just about done, but they're allowing us to keep it all together, keep wipes and diapers in our 1115. Now we have to pay for those individual items out of our waiver savings, which is fine. We agreed to that from the beginning, but it will be one complete package. So we're pretty excited about that.
Well, I think it's interesting too, you highlight, right? And maybe advice for state leadership here and advice for health plans, right? Health plans. I don't want to speak for these two professionals on here, but right. I know both of you have said offline too, and other people have said, like, we like our health plans to bring us innovation, like help us get there, right? States can start with small pilots or programs to validate the ask here, but whether you take it down a demonstration or in lieu of, right? We know we can target populations at risk. We know nutrition stabilizes these populations. And to your point, it promotes engagement. It brings opportunities for supplemental support services. Maternal health is such an ongoing challenge that we all talk about, deal with. And going back, I love Stacey's comment on humanity. I mean, my goodness, if we can't take care of our moms in the country, right, or that are at risk for issues, who can we take care of? But we are seeing a lot of pathways for maternal health in other states, where whether it's a demonstration or in lieu of, where we can start to kind of, I think, scratch away at some of the issues that are causing some of these problems. We can start simple, start small, but we can scale it to support these individuals to make sure we're helping them with their health conditions and challenges and all those other things you talked about with engagement. I think that's an amazing example for.
And that data for that pilot was so good. I mean, we could target zip codes, and we found that the individuals who were using the program and who said yes to doing it were in our most vulnerable zip codes. We have data on race and ethnicity. So it was much easier starting smaller to be able to demonstrate. That's what 1115 waiver does. You're demonstrating why you want to think outside the box. And so I highly recommend a pilot.
Awesome. Thank you. Stacey, I know you'll have a different program, different pathways, and we're really excited to hear some of the great work happening in Nevada. Again, every state's different. That's the one common theme across Medicaid. Every state is drastically different. So if you want to highlight some of the Nevada work and some of the great things you're doing there.
Well, I love listening to Kathleen. I was just getting other ideas for next year. So thank you, Kathleen. It's always fun to share stuff because every state is brainstorming and trying to solve the same problems, but differently. Because they're different still and unique. So let's talk. I want to talk a little bit about, just first of all, it's rare that I give health plans credit, but I will give our health plans credit that they are doing, I think, before we even started in lieu of, they were already offering housing supports and meal supports. They saw the value early on. I think we all see the value, not just from the humanity side, but also from the business model that managed care is supposed to be designed. That's the whole point of the business model, right? Is to try to get healthier outcomes and managed care, right? So there was already some of that going on. We saw what California got through CMS. And so immediately I said, we're jumping on that train, and we need it too. And, we're putting right now, we're waiting for approval of our amendment. I hopefully expect it here soon, and we'll be covering these services January 1. But there are several buckets of housing supports, and meal supports falls under the housing sustainment services.
Yep.
That's kind of how we're arguing. It's a sustaining people in their home and sort of that stability. They have to be medically appropriate, right, and reasonably necessary to make sure that they're sustaining safe and stable housing. But also, it's not just the meals. We're also looking at 2 medically tailored meals a day. Otherwise, it's room and board is kind of CMS's argument, which I would still push back on that. But that's, we'll take 2. I won't be greedy. But
You all take that argument with CMS, but
I'm like, I'll wait for next time, right? Let's just get the 2 right now.
Absolutely.
And hearing Kathleen say they had 1, I was like, oh, I guess we're lucky right now.
I'll go with you for that argument.
Okay, Kathleen, let's go. Because I'm like, that's not room and board, but okay. And then we're also providing nutrition services and education. So we're going to cover those types of services if a health plan can find the right type of partner and provide organization to provide those services to eligible members, as well as healthy food vouchers. We're looking at food pharmacies, groceries, medically tailored grocery shopping for people, cooking classes. Obviously, they can't be longer than 90 days. You have to be part of some sort of counseling. So there's all these like little caveats I think CMS wants. But it's a pretty broad definition that's in our contract amendment that I think gives plans some ability to be creative. And that's what we want to see. I think, my goal, my fear is that the health plans will only do it in small bits and pieces. And to make it truly cost effective, is we need it to be offered broadly. I think we can't just do one-offs. It's got to be, if you're going to do it, optional benefit. We need to really do it to make the cost-effective argument, because that CMS added a lot of guidance. I get why they did that, but it has made that benefit challenging. I do want to talk about 3 other ideas that we have, or tools that states can use. I mean, again, our managed care program is a state plan benefit, so it's not a 1115 waiver. So I'm thinking more in that realm. So in lieu of, is in an optional benefit where plans can use their Medicaid capitation payment dollars to pay for. You all probably know about value add, the added benefit, that's where they can use their profit. So for years, they were using value added benefits to do some of this. So now we're flipping it to the Medicaid side and saying, do it more with more people. And here's the population we think really needs it right now. We're targeting it.
Right.
The other 2 ideas I want to throw out, again, I mentioned earlier, the community reinvestment dollars. So really, if states want to think about that, but even plans want to push that, it's an opportunity to get credit, right? And to also reinvest some of the profit back into the community, which also I think gets them goodwill with some of the providers and the community. Like, I think what plans probably don't want to do is they share their profit, but I think they have to remember the goodwill that they get from their community partners in doing these types of things. So there is goodwill in doing that, but also it helps their members get services for social determinants of health and addressing those needs that we can't typically pay for. And the nice thing is it's not tied to a service billing. Community reinvestment can be a grant to an organization. It can be infrastructure. These are the things that Medicaid can't typically pay for, but we all know we need to get where we want to be. So I think community reinvestment is a really exciting new tool that, like we're using it and a couple other states are using it.
Yeah, I like that.
And the other last one that we started 2 years ago, last year, now we're doing it again this year for a contract year, is a bonus payment program. We're using our bonus payment program right now to really drive primary care spending. So we're asking, if you meet a target and increase your spending on primary care services, you get a bonus payment. It's essentially a rate increase.
Right.
It's like 1 or 2%, which matters. And then the other piece that we're using right now is for value-based payment design, which if you're doing some of the bigger models around attribution, you really do need to manage a patient's social needs to make sure they are getting healthier. So I would hope that health plans can use that bonus payment for some and really invest in the social determinants of health and social services. But I do think states can structure those bonus payment programs if they have the funding to do that on top of the rates to really drive food or drive other priorities. Like we're going to be doing a new one around maternal health now this next time. and maybe we do more, the future years around social determinants of health. But it's another tool that I've seen work with plans. They want that additional rate increase. They want that additional money, and it gives us value in giving it to them, right? Because it's getting at our priorities. So those are the tools that offhand I can think of. And then obviously the other one we've toying around with is the prison waiver that we're, for incarcerated pre-release waiver. We're all asking for one. I think there's that might be the backlog, and that's why there's a backlog right now.
That's the cause.
Yeah, there's 100 or 50 of us waiting for waiver approvals. But one of the things that we're going to be looking at is food supports and stability supports for this population coming out, right? Like helping them, wrapping around them what they need to stay in their community and stay healthy.
Yeah, good points. And you brought up some great examples. I love the three that you just mentioned, Stacey. That's amazing too. And it sounds like across every state, right? The one common theme is there are multiple pathways that we could target food insecurity and other social benefit programs, right? You touched on California. California took a big leadership. They have a very robust in lieu of service community support program, right? To your point. And I think other states are kind of looking for that. Some states have wanted to have a more scaled down version, right? Some states are looking at different pathways. So for both of you, and I love those examples, Kathleen and Stacey both. So pie in the sky, right? We have amazing health plan partners on this call. Like, what is your general guidance to the health plans? Like, in the states that they work in, right? What can they bring you as state leadership, right? To help you and align with you on creating these food as medicine pathways. Like, if you could tell them one or two just takeaways, what's the easiest button for them to help you innovate and target certain populations? Stacey, you just mentioned maternal, of course, that's always on that list, but what is one or two takeaways that you can lead them so that, okay, they come to you with some of this innovation pathway? I don't know who wants to start. Kathleen?
I wanted to just follow up to what Stacey said, and I wrote a lot of that down, and I'm right back at you, coming your way to get some things ironed out there. One of the things that that we do know, all right, social determinants of health are a part of an individual's medical complexity, just a fact. Promoting healthy eating it is medicine, and anyone who argues that, I'm ready for that discussion. A healthier feeding someone and making sure that they are getting what they need makes them a healthier member. Healthier members are cheaper to manage. So you have to look at it. You can look at it because it's the right thing to do. It's going to make their quality of life improve tenfold, but it's also going to lower your cost in the long run. If a diabetic is eating the right medication, the right food, medication, as part of their everyday regimen, then they're going to be cheaper in the long run. And when you're looking at, as an MCO, looking at your statistics, and those high dollar individuals. So putting that as part of just, they're taking their insulin and they're getting their good meal, it makes a difference. So just wanted to follow up with that. It in the long run is cheaper. And it's not that expensive to feed somebody. But it sure is expensive for a 4-day stay at a hospital. We can go down that track another day. I think that one of the things, states are just so overwhelmed with changes. What did we get? 14 directives from CMS recently about changes that we needed to make. That's on the Medicaid side, but also our partners at our aging units on aging in our states got a bunch of changes. So we are, and I think the most, and I've been doing this with Medicaid for 23 years, the most we've ever gotten at one time. So I think as our partners at our managed care, you can run statistics and analysis on what our members are, where they're utilizing what their diagnoses are, and what zip codes they're coming out of. Data is everything. And there are some states who do data very well. Washington State, top of the heap there. Like, they have a data analytic program. Some of the other states do. My state does not, right? And so our managed care, I have some great managed cares in my state and true partners. And so when I'm like, I need some data, they do it. So look at what and ask what, as a managed care, what you can do to help the state to be able to get you from where they are to where you both want to be. And I think that that would be the biggest help, is to finding out what's missing at the state other than being overworked and underpaid, but that's also another discussion. You know, what you can do to help with that. And I would say that would be the biggest.
No, that's a great point. Partnership. And again, I'm encouraged because my conversation with both you and other DHS leadership plans, like, bring that to your DHS partners. Like, they want to partner with you to do it. I think, right, if we're not going to do it now, when are we going to do it? Right. All of these pathways for kind of various foodist medicine pathways. And Stacey, you covered so many different amazing opportunities, right? Again, each state's different. But end of the day, if we're not going to do it now, when are we going to do it? I went to a conference a couple months ago even, and there was still like some debate on, okay, you know, we really need to study how food can provide right outcomes for people. I think it's been fairly studied right now. Like, okay, what are we going to do to bridge that gap? To your point, the workload at our state governments is wide and long and vast. They don't have enough resources to independently create these pathways. And I think they depend on their managed care partners to help them bridge that gap. Stacey, any thoughts on your side too? I know, again, each state's different, of course.
I would just say amen. Amen to Kathleen. That was really well said. I don't know how, I want to be careful how I say that. I don't want to offend anyone, but I do feel like, here's what I'm watching for. I don't want to see plans coming into our state in the next procurement, which is coming up soon, who are just saying they're going to do these things and then do denials and prior authorizations to make money. You know what I mean? And so we're watching, we know the game. My goal is I want you to be a partner in improving health. I want that to be the way you make money, not the other way. So help me. Otherwise, I think there's, and that's the reality. Like, there are good partners and there's not. And in our procurement, I'm looking for that. I'm looking for solutions to problems. I'm looking for creativity. I'm not looking for like soft promises. I'm looking for like real outcomes and help. And it can't be what I get from a lot of providers is this plan just denies. And there's a trend, you know, or, you know, I struggle with that because I get sometimes there are reasons to deny. We have to, and there are reasons for prior authorizations. I get that too, but it can't be the only tool that they were using to control costs. It has to be about the health. And yeah, it's not going to be driving a lot of costs quickly. Sometimes that's the faster way to do it, is to tighten your prior authorization process and all those things. But that's not what we don't want. We want a good healthcare coverage system that's about improving health, and food is a part of that.
Yeah, absolutely.
And so help show us what are your ideas, because we have some huge challenges in our rural areas.
Yeah, absolutely.
And healthy food access, and we really need the help. And that is what I'm looking for, is real partners and not just businesses, right? I get it. We're all businesses in some way. Medicaid is the biggest payer in my state. Let's face it. Besides employers coverage, but that's a different thing. But you know, like, how can you be a partner and our goal and mission, which is improving health, and still have a good business model? Like, that's what I want to see.
Love it. Yeah. Excellent point. Excellent leadership from both of you too. And we're about to turn over to Q&A. I just wanted to kind of close out if y'all had any closing comments before we get into the Q&A. But again, Stacey, go back to the humanity conversation too, and to your point of what you just said in the partnership, and Kathleen, your leadership in Delaware. You all, again, if not now, when? We have these pathways ahead of us. We could modernize both home and community-based service waivers, 1115s, in lieu of services, go down all the list of things we talked about today. But not us today, but it's been proven that food is medicine, especially for vulnerable communities and populations. Like, what is the practical, person-centered way to partner together and really address these, right, in upcoming procurements, but just in general, right, as we're just taking care of people and providing that humanity and dignity to our most vulnerable community. So I want to thank you both for just great comments. And anything else before I turn over to the Q&A? Good to go? All right, Patrick, I'll start looking through the list here about any questions that you want to queue up for us that we can talk with the team about here.
No, I think you may as well start with the Zoom questions. But gosh, we got 9 already. So folks, what we'll do is these have been captured, and I will send these questions to the panel so that they can get in touch with you. So if we can't get to your question, don't worry, they have them. And then of course, you can reach the panelists through MHPA, just ask us, we'll connect you. Or obviously, you guys can put it in the chat, your emails, or however you want to do it. But if nothing else, MHPA can connect you guys if we can't get to your question.
Great. Sounds good. So Patrick, I don't see the questions. I don't know if you're going to pose
I do.
them.
I can see
Okay.
them. Yeah. Do you want me to read it?
Yeah,
Sure.
please go right ahead.
Okay. What if we want to direct food is medicine programs for women in their postpartum phase? Well, right up my alley. So I think we already talked about how Delaware ran a pilot program, and now we are moving that into our 1115 waiver. So it is part of their benefit. So I don't know if the individual who asked that question, it might have been answered when I talked about that. But if you have additional questions, if you would put it in, that would be fine. I'd be happy to talk about it.
Yeah. One thing too, to supplement what Kathleen said too, and what we're seeing across other states as well, and Delaware's done a great job with leadership here, but right there is a substantial amount of 1115s that supported coverage of Medicaid postpartum, right? What we did not see in a lot of those demonstrations was a food as medicine addendum to that. So we know that's one opportunity. We're not saying that's the easy pathway, but I think we're seeing a lot of the VABs and in lieu of service programs out there to kind of supplement support states to get to whether or not they want to addend their 1115s or add a new food as medicine 1115. But yeah, again, goes down to that state level focus, you all, right? There's opportunities and pathways for that specific population that are emerging. So whatever we can do to support that conversation. Great question. Kathleen, if you want to be the question arbiter, I still don't see them in my list. So if you want to go through.
I got it. Yep.
Awesome.
Wait. I think they may have. Here we go. All right. So, Kathleen, 50% utilization. Can you define that a bit more? Is it 50% of all members or eligibles? Or question, it is 50% of all individuals who were eligible for meals were utilizing that benefit.
And I do see them now. Thank you. They open up the Q&A to me as well. So with that point, Kathleen, too, and for the perspective across the country, you all right? Some states don't track utilization of their home and community-based service waivers, right? And that's an emerging thing. So we're starting to see that pathway emerge now. And to Kathleen's point, Delaware tracks it. And first step is just knowing the data, right? And Kathleen, you talked about this with your health plans, right? Partnering with health plans and understanding that specifically MLTSS states, we're seeing a lot of opportunity to target, right, food insecurity among those home and community-based service waivers by just tracking that data and looking at that. But we know specifically some states as low as 10 to 15%. And there's two ways that, we see, and Stacy and Kathleen jump in here. One, their waiver language may be restrictive of meals existing, right? For just the presence of food insecurity, that really is the biggest qualifier for meals to be, authorized under a home and community-based service waiver. So as you add supplemental restrictions that cause that waiver to be more restrictive, that will lead to some lower utilization. And again, CMS has given guidance on flexibilities of some of these waivers to target food insecurity. There shouldn't be a lot of competing interest for that. Back to the dignity question, if we just ask a person if they're food insecure, they may not be the best way to get confirmation of food insecurity. There's other factors that cause some low utilization with existing waivers. Any other comments on that?
I think that one of the things you have to remember, if you have an individual who is in a long-term supports and services program, they've already had to medically qualify to be in there. So CMS is pretty lenient there because they know that the population itself, it's the acute population that we have to sometimes demonstrate. And again, just having given birth is not enough to be able to qualify for the program. So we are being very creative on how we advance that now. Yeah,
good point. Another question coming in here too. Multitasking is always interesting on a virtual webinar, so bear with us all. Population segments. One of the questions came across, and we see several of these. Like, how are we using some of these pathways to target like chronic care populations, dual eligible populations? We always hear the buzzword around duals integrations, but that's not an easy thing to accomplish at the state level, right? Across Medicare and Medicaid. So what are you all seeing from populations that are targeted, and maybe specifically around dual eligible populations where these pathways can be, I guess, substantive in supporting food insecurity for those populations?
So like I said earlier, we don't have seniors and the duals in managed care. Not to say we won't in the future, but if we do, I think meals is critical to this population. But we're focused on the at-risk of homelessness and the homelessness population, which is a lot of behavioral health needs, and also pregnant women. So that is another individual if they're at risk of homelessness, and supporting them. So we are targeting it because that's the best way to do cost effectiveness. You have to find the high cost, where can we get the most value? And not say everyone, in my mind, everyone should have access to food. It doesn't, but how can I prove cost effectiveness? And this is these high cost populations, I am going to see better outcomes for like high risk moms or people with behavioral health needs coming to the ER, having support in their home, and food keeps them stable in some ways as well. So yeah, I think it all depends on the tool and the track you use to do this, right? Because we all, like, you can go down the waiver route, you still have to prove budget neutrality, cost effectiveness has its own, it depends on what you have to do to get the coverage, right? So unfortunately, it's not like, oh, we just cover it. We have to prove that it's not going to cost money, or it's not going to, it's going to be a savings and all these other things. So I do think you have to target it to your more costly, high risk populations.
Excellent point. Excellent point. Another question here too, and you all jump in here at any time. And a good point from an anonymous person on the chat here. We know food is medicine. We know cost neutrality, to your point, Stacy, right? You just mentioned in validating some of the demonstrations or in lieu ofs, right? We know food does that, but from a health plan perspective, right? And how they validate, right, investment maybe differently than how a state looks at investment. How can health plans, I think, better validate the ROI around food as medicine, right? We have pilots and studies and different things that can be used, but from your perspective, like, what can health plans do to really demonstrate that ROI? To your point, Stacy, right? So they come with more substantive programs that really target full communities, rural settings, duals, or whatever that is, right? And what are your all's perspective in how health plans can really validate that ROI?
So for me, as a state, if I'm looking to advance a program in my state, I'm going to put it in as a requirement when my RFP goes out, just at its very basic. If you do that, their bid, the MCO's bid, and they're on here and they're very well aware that is part of their contract. So it's more about put in what you want. And it also gives the managed care organizations, when they're bidding, a targeted avenue. If you're very clear when you go out for bid, what you as a state are looking for, then they can be very clear on what they're offering. So I think that's even where the conversation and the communication starts, is before they even bid. If you're clear about what you want, they can absolutely. It costs a lot of money to bid on a state. We understand that. It's a lot of money for us too. It's a lot of work. And being, instead of leaving it up to what are you going to do for me? Let me tell you what I want you to do for me. And I think that, a state can really benefit from that. The other piece of that is, once it comes in, the state has the responsibility to do oversight on it. Just because you say you're going to do it, I need to make sure you are. And I think that if you're not able to as a managed care, and we've had this happen, they come to me and they said, listen, we're trying. We are having a hard time with, A, B, and C. All right, let me help you break down the fence of A, B, and C so that you can give me what I really needed and you said you were going to give. So it's that continued action that needs to happen on both ends, I think.
Yeah, good point. Great point. I think we have time for one more question here, and I'll pose it to both of you, then we'll start to wrap up here. There was a question from the audience. What do you see as the focus on grassroots community efforts to tie into larger adoption plans for food as medicine? I know I have a thought there, but I'll turn it over to you two first.
So I think it's huge. I mean, social services, and determines that all the people working on those issues are grassroots communities. They're not your typical provider system. So I think the challenge in us covering services in a health insurance model is how we treat these organizations and how we leverage them. And I think if what I'm trying to do through the in lieu of is not require them to enroll in Medicaid, then we're never going to get this done. I mean, they're not a provider. They're not going to bill us the same way. So I just want to pay the health plans to pay them, and whatever payment model works for them. So I think we have to remember, if we're going to do this, we need to remember these are community organizations often that are not sophisticated in billing and all the other things. And how do we create a payment model and business model with them that supports them? And so we can get these services out the door. That's where I struggle, is like making sure we don't treat this like you have to be a provider and you have to, it's just not going to be sustainable for them on these non-traditional providers now of services in some ways. So I think it's really important that we understand that, and we ask our health plans, and the plans also treat them in ways that's with some flexibility so it can be sustainable, because we need those community partners that are doing these services to participate.
Yeah,
So
good point.
I hope that answers the question. I don't know, but I think it's important. Yeah.
There may be a few answers. One thought here too, and I don't know anything else from Kathleen, and we'll kind of wrap up here, but we're seeing a movement across the country too, right? When we talk about food as medicine as well, right? Stakeholder coalition meetings. Now, I say that kind of loosely just because they may look very different in each community in every state, but to kind of give a collective voice to some of the grassroots community-based efforts, right? There may be CBOs involved, there may be local nonprofits. And Stacey, to your point, right? And they don't have the substantial funding to really build up statewide practicality, right? But as a united group, right, sitting on a coalition, really elevating those grassroots needs and efforts, they can speak to that better than anyone else, right? So that's, to me, it goes back into, right, building these coalitions where those voices are heard and they sit amongst, right, the other provider networks and the managed care plans, so that we can come as a united front to solve statewide issues, which may mean, right, small community-based needs that would not have existed without those grassroots initiatives. So that's a great question out there. Anything else from either one of you? And we'll start to wrap up.
I think that one of the things that we need to focus on is really getting benefit packages for our acute populations.
Yeah,
I think we've tackled our LTSS population. I think that we're looking at maternal, but we talked about duals. We moved our full duals into our managed care benefit a long time ago, and they have a great package, and we take pretty good care of them, but they're not afforded. If they don't want to apply for long-term supports and services and reduce that, that resource to the resource limit, then they don't have to, but they still have needs, right? And we still need to keep them healthy. So I think that's a focus Delaware will take. The other big focus is we have to talk about our at-risk population who are not on Medicaid yet. Delaware's doing a program now, just finishing, the crossing the T's, dotting the I's, that we're going to, provide meals to our chronic, end-stage chronic renal disease folks, so that when they go, the days that they go to dialysis, they're just wiped out. They're not able to cook for themselves. So we're going to be providing them meals. Mom's Meals is a partner in that, and that's how kind of we hooked up, to be able to do this. And so they are not on Medicaid yet. It's a state-run program. So once, the at-risk population is eventually going to be on Medicaid, the healthier you can keep them, the better off our program is going to be, and the better off and easier it's going to be able to manage for our partners in managed care.
Awesome point. Yes. So I'm going to share some closing, a slide with you all just for contact purposes too. Let me wrap up this really quickly here. My apologies. All right. Thank you. Excellent questions. Thank you again, MHPA. We appreciate the partnership and your advocacy towards high-risk populations. I want to thank specifically Stacey and Kathleen, both amazing people that are leading innovation in their state. And to summarize for the group, right, please feel free to download. We have a white paper talking about some of these initiatives and how we innovate around food insecurity. But again, states partnering with health plans, right, partnering with provider networks, right? Every state is different. But to end this right on a high note, right, some of the great concepts and discussions from Stacey and Kathleen, right? Let's start the process together, right? Teamwork and partnership. Let's target our most vulnerable communities. We know food is medicine. How do we create that pathway in each of our states through that collective partnership? So wanted to thank again MHPA, Stacey and Kathleen for joining us today. Thank you for your questions. Reach out to any of us through MHPA or through this webinar, and we would love to support you in these endeavors at the local level. Hope everybody has a safe and happy holidays, and thank you for your time today.
Thank you, Tim.
Thank you all. Bye-bye.